I'm Jane. I'm a research coordinator. I work with Mary and Aaron under Dr. Bird, who's the chief of trauma here. And so my goal for the presentation is just to teach you all a little bit about the research efforts we're having right now and how it can be used to improve patient care. So for a little background, trauma is the leading cause of preventable death in children, and 4% of trauma activation patients do not survive until discharge. A quarter of those deaths are actually preventable, and half of those preventable deaths are related to errors during the initial trauma resuscitation. So these errors can be classified into 3 buckets. There's knowledge-based errors, which are when the provider lacks essential knowledge in order to take care of the patient. There are skill-based errors, which involve the provider just not being able to successfully perform a procedure. And then there are rule-based errors, which are when a provider deviates from the established protocol. 85% of the errors leading to preventable deaths are these rule-based errors that are due to the provider not following established protocols. So what can we do to stop these preventable deaths? As I just established, these aren't based on clinical knowledge, these aren't based on surgical skills for the most part. For the most part, it is these rule-based knowledge, and so developing more clinical algorithms and stuff like that aren't going to be necessarily helpful in stopping these preventable deaths. So really, providers need to work smarter and not harder in order to help stop these preventable deaths, and this is what our research is really based on, is creating these decision support tools in the trauma bay to help providers with their decisions and patient care. So the first topic I want to talk about is our overall decision support. It's under this R01 grant, and we're basically focused on implementing real-time decision support in the trauma bay so that providers can have some sort of backup into why they're making the decisions that they are. So the simplest form of decision support would just be a checklist or something in the trauma bay where a provider would go through and note every single thing that's happening during the trauma resuscitation. But as you all know, trauma resuscitations are very chaotic. There are sometimes up to 20 people in the room, and all of these people are doing their own tasks on their own time. So as nurse left is getting a manual blood pressure, the resident might be doing the primary survey, and nurse right would be getting the patient hooked up to vitals. So it's pretty impossible for this one provider to note down all the different activities that are happening at the same time in order to get a real-time decision support. So our team goal is to create a decision support with these things in mind. So our first goal is to have this decision support tool be able to recognize and track team goals in real time. So for example, that goal might be to establish IV access in this patient. The next step is for this decision support tool to be able to identify and prioritize these activities. So sticking with the IV example, an activity associated with getting IV access would be the application of a tourniquet or performing a flush. And then the final step of this decision support tool would be to recommend a plan of activities. So imagine you're trying to get the IV in, the high acuity patient, and this IV is just not going in. The decision support tool would be able to recognize that putting in this IV is delaying patient care and would maybe recommend an IO placement. So in order to do this, create this decision support, we are using machine learning. And so we have 4 different types of data modalities that we're looking at. One is video, one is audio, the vital signs, and then a digital checklist that we developed for the surgical coordinator to use. So as you can see, we have cameras in the trauma bay. We have 6 cameras now that provide basically every possible angle you could need to see everything that's happening in the trauma bay during the resuscitation. We also have 2 microphones that record all the audio during resuscitation. And then we have this digital checklist that we developed that's always on this table. The surgical coordinator, when they come in at the beginning of the trauma, can pick it up and use it as like a checklist decision support to help them through the trauma. And then finally, we have the vitals monitor, which connects directly to our decision support tool and puts the live vitals of the patients into this decision support tool. So we now have this TV up in the upper right-hand corner that can display anything from vital signs to alerts and eventually the recommendations that our decision support tool is going to be implementing. So this is a view of the trauma bay. These are 3 of the camera views that we have. So as you can see, we have one above bed that looks directly on the patient, one from the back of the room that just sees everything, and then one that's focused specifically on the team leaders. So this we use a lot for our research, but then also other members of our trauma team use it for quality performance improvement purposes. So in order to create this decision support tool, this machine learning, we work with 2 other teams, a team at Rutgers and a team at Drexel. They help us with the computer engineering and the informatics side of things. And so in order to create a machine learning tool, first you have to get the data, and we download every consented trauma activation that happens in our trauma bay. We get the video and the audio records of all of this, and we use that to create a ground truth and have it go through our computer system. And so in order to establish a ground truth, we use this this program called Mangles, and so we can use this to write down the activity, the start time, end time, and any type of attributes associated with it. So in keeping with that IV example from earlier, if I'm noticing that a nurse is putting in an IV, the second they put the tourniquet on, I'll start the time, and then once they actually have the catheter secured, I'll end it. And then if they've said to the room the place and the size of the IV, then I'll put that it was like vocalized to the whole team. So that establishes our ground truth. And we have this for many, many videos from several years, and we take that ground truth for what the computer is supposed to take as like, this is fully occurring, and we run it through the computer system. And the computer system takes that, learns from it, and then as we keep running more and more videos through it, it improves its performance and prediction of these activities. And then once the computer is trained, we put through videos of trauma resuscitations that have not been coded for these ground truth activities, and the computer puts out a probability of what is occurring. Some of them it's really good at, so like log roll, it has 0.8% probability, versus a manual inline, it's only at 0.45% in that specific instance. So then the computer will send that back to us, and we will take it and say whether or not that activity was really performed. So those ambiguous activities like the manual inline will go back and be like, yes, this happened, or no, and then feed that back into the computer, and it, again, improves the performance. It's kind of like a circular process for a little while, improving it. We also, as I mentioned, have lots of microphones in the trauma bay. There are 2 of them, and we use that, again, to create this audio prediction and decision support tool. So We also establish a ground truth like we do with the videos. And so, for example, we're listening to a case, we hear a provider say he's got good pulses peripheral on the right, then the transcriber will write that down and associate it with circulation. Then, as with the video, the computer trains on all of this information, and then we feed untranscribed audio through it, and it'll give out their own transcribed case, and then we go back through like we did with the video and put corrections to anything that they got wrong. So we review the outputs, we make the corrections, and identify what the speech relates to. So our team has also developed this checklist. This checklist is, as I showed earlier, it's on a tablet in the code room. Any of the team leaders, when they go into the trauma bay, will pick it up at the beginning of the resuscitation, and it's really a checklist of things that need to happen in order to get the patient to the next step and make sure that they're stable. So it's just to make sure they don't miss anything, they have everything they could need. So our decision support tool has this pre-hospital information form. And so the provider will take any sort of information they get from the EMS report or the page and put it into this pre-hospital form. And then once they submit that, it'll actually pop up a one-line summary of what the patient's condition is on this TV in the trauma bay, so that anybody who is coming late can see what is happening in the, for what happened to the patient. And then that clock also, it automatically starts when the patient gets placed on the bed. That's part of our video recognition system. So then once the provider has filled out the pre-hospital form, they'll go on to the form that has the primary and the secondary survey. It's really meant for a decision support, so we have some interesting things that are really helpful for these providers. So I think the most important thing, in my opinion, is the vital signs. They now come in automatically from the vital sign monitor onto this checklist, and they will be color-coded as green, yellow, or red, depending on the patient's vital sign or the patient's age, if the provider has put in the age on the checklist. So that can be really, really helpful, especially with these residents who are only doing one rotation of pediatrics. And then they can also click on the little heart symbol, and it'll pull up a trend of the vital signs, and that can be really, really helpful to see if these patients are doing well or if they're like starting to decline as time goes on in the resuscitation. So most of this data is just supposed to be used for the own like help and thought process of the provider, but then we also collect all this data and use it to help improve our systems and eventually to help create these decision support tools. So our system takes the video, the audio, and the checklist data, we run it through the system, we take the vital signs, and then that pops out a recommendation. This is our ultimate goal of this research, is to create these recommendations. So for example, it can pop up on the checklist or on that TV display where our system takes everything that's happened and might recommend that the provider consider blood transfusion. So it's really a lot to just teach them, like, or show them what could happen, what they might need to do next. So as part of that, we use this modeling system to create, we do simulations in our trauma bay to show that like this is really helpful and important. So many simulations. Cindy has been recruited for a lot of them. So again, it's just the microphone, the video, the checklist, all to put out this recommendation. And then our team kind of plays the role of the different people in the trauma bay. And while we are performing the different roles of people in the trauma bay, our recommendation system will spit out reminders and recommendations as the simulation goes on. So for example, we put the patient on the bed. We have these 4 reminders on if it's a blunt injury type. Once we put the C-collar on, that reminder goes away. Once we put the non-rebreather on, that reminder goes away. And so it's like our video and audio systems are recognizing all these things in real time. And then as the simulation goes on, it will populate a recommendation on the screen. We have participants, they're acting as the attending or surgical leader, and they'll kind of look at their TV and see if like they agree with that recommendation or not. And it's really to see if our recommendation system is helping to improve or like shorten the amount of time to a decision. So the next project I want to talk about is also focused on reducing time to a decision, but it's really focused on what's happening both before and during the trauma resuscitation. And so it's a network that helps the provider decide whether they need to intubate the patient or not. So the problem is inadequate airway management contributes to preventable trauma deaths, and failure to rapidly secure these airways is a cause of up to 20% of preventable deaths after injury in children and adults. Early recognition of inadequate oxygenation and ventilation, and then the subsequent prompt intubation is associated with reduced mortality and morbidity, and it reduces ICU stay and the incidence of multi-organ failure. So many people have tried to create decision support criteria, tools to help facilitate this decision to intubate. The Eastern Association for the Surgery of Trauma, or EAST, developed guidelines that helps the provider decide whether to intubate based on certain signs and symptoms. But these are mostly like based on the provider's judgment and can be really subjective. So it ultimately doesn't really help with the stress of making that decision. There have also been a couple machine learning tools created for this. But one example of this machine learning tool, it actually uses the AIS injury severity score for body regions, which is a really difficult factor to grab in the trauma bay. And then another one, another machine learning tool actually uses 53 different factors, including lab values, to create this decision support, which is really difficult to obtain and causes a delay to intubation. Also, none of these actually do anything for children. None of them have been validated for children. So our goal was to create a model that was specifically for children. And we wanted a tool that takes advantage of all the information that's immediately available on arrival to the trauma bay, such as like the patient's mechanism of injury or whether or not they had pre-hospital CPR. We also, a lot of the triage tools that people use don't work if not all of the variables are used. So we wanted a tool that you can use if you have missing information. We also wanted a tool that doesn't require time-consuming or difficult labs to obtain, such as the lab values or the AIS scores. And then finally, wanted to update as more information becomes available. So in order to do this, we're using a Bayesian network. Not sure how many of you have heard of this before. I hadn't before I started here. But basically, it's a network that takes input probabilities and then so in this case, it's like rain and the sprinkler use, and then has an output probability. In this case, the grass is wet. So for this scenario, say there's a 20% chance that it's going to rain, then there's only a 0.01% chance that if it's raining, you're going to use your sprinkler. Because why would you use your sprinkler if your grass is already getting wet from the rain? So then it takes both of those probabilities and puts it into the final probability of whether or not the grass is wet, and taking that it's raining, but the sprinkler's off, you have an 80% chance that the grass is wet. That's very basic what a Bayesian network is. So to do this for our intubation, we needed a very large data set. So we took 4 ACS pediatric trauma level 1 verified centers, ours, Cincinnati Children's Nationwide, and UCSF. And those, we took all the data from, I think, January 2010 to December 2021, and we excluded any patient that was intubated pre-hospital so that we could solely focus on those in the emergency department. And that ended up giving us a total of 20,255 patient data that we can use. So in order to choose variables, we had to decide which ones would be really helpful. And so we trained our model using the patient injury and resuscitation characteristics from 3 of the 4 sites, holding out the 4th site for a validation. And in order to do this, we wanted to rely on something other than just clinical judgment. So we used a Bayesian network, which really helps to choose the variables that are most important. And we just threw all of our data in there, and it kind of spits out the most important variables that you need in the final model. So we ended up having, with that Bayesian lab and with clinical judgment, we have 5 predictor variables predicting whether or not the patient would get intubated. So those are mechanism of injury, injury type, GCS, age, and blood pressure. And so then, as I said, we used the 4th institution as our external validation data set. And we actually just submitted this paper for publication, and we're really hoping to use this decision support tool in the future in the trauma bay on that TV display that I showed earlier to really help these providers make that decision to intubate earlier. The next study I want to talk about is this massive transfusion in children 2, or MATIC-2 study. It is a multi-institution controlled phase 3 clinical trial, and it's going to start in the summer of 2024. So what is the problem that we're trying to assess? Bleeding is the leading cause of preventable death after injury in children, and approximately 2,000 children die per year in the U.S. from traumatic hemorrhage shock, which could be prevented with a more timely and effective care. Mortality rates at 28 days in injured children with life-threatening hemorrhage ranges from 36 to 50%, which is approximately twice the rate of injured adults. But despite the fact that children have this very different response to hemorrhagic shock from adults, the pediatric trauma resuscitation guidelines are derived from adult data because there isn't sufficient research to help these children and their resuscitation process. So our idea is to optimize the transfusion strategies in children with these traumatic life-threatening hemorrhages. So we want to investigate the mechanisms of the trauma-induced coagulopathy and the biologic responses of these different resuscitation strategies. So in order to do this, any injured patient that comes in that's predicted to need massive blood transfusion would be enrolled in this study. And we are seeing, and they're going to be automatically assigned to one of these treatment groups. So it's to see of the low titer group O whole blood versus component therapy and TXA versus placebo. And so our hypothesis is that whole blood is non-inferior and or superior in 24-hour mortality, and that it does not increase the risk of adverse effects or outcomes compared to component therapy. And then also that TXA is superior in the 24-hour mortality compared to placebo. So in order to do this, it's a 20-site study, and we will most likely just be put under one treatment group for the first year. So for example, if we're in group 1, the first year are any patient that comes into our trauma bay that needs massive blood transfusion will be getting whole blood and TXA. And then the next year it would change to component therapy and placebo. And so it's supposed to last for 4 years, and at the end we would compare the outcome of all these patients using the different resuscitation characteristics. The last, you're going to have to explain that for me. Maybe Mary can explain it for me. All right, last but not least, we have our computer vision PPE monitoring system. So what's the problem? During COVID, the healthcare workers had greater than 11-fold higher rate of infection than the general population, and several risk factors have been identified. The inadequate use of PPE was associated with a 1/3 higher risk of infection. So the CDC recommended that everyone employ a trained healthcare worker to observe the donning and doffing procedures of healthcare workers in the hospital. It's a great idea in theory, but when you have a lot of people in the same room, they can't just look and observe everyone at the same time, so they do fall short in that. So we are creating a computer vision system, our CAP system, that helps to detect these non-adherences. And it's supposed to, our theory is that it will detect them faster and more accurately than a human would. So we use a software called V7 to put bounding boxes around any type of PPE to help train these computer systems. And so we're looking mostly at gloves, gowns, whether they're complete, incomplete, or absent. Eyewear, we're looking at pretty much everything: poppers, face shields, safety glasses, goggles, prescription glasses, and then for masks, we're looking at N95, regular masks, and then incomplete masks. So we put bounding boxes around all these types of PPE. Again, as before, we train our computer vision system based on this ground truth. And then we're now performing experiments to test our PPE computer vision system to see how it performs, and especially we're looking to see how it performs versus humans. So we've actually been recruiting a lot of nurses to do this PPE experiment for us to help us just show whether humans or computer do it better. So you all can get involved if you want to. We're looking for more participants to help us with this study. You get paid. It's just 15 to 30 minutes, and you get a $30 Cling card payment for doing it. All you have to do is jump on your computer with Erin and myself for 30 minutes, and you just have to kind of track the PPE. It's very, very easy. It's all over Zoom. You can schedule it for any time. But if you would like to, we would love for you to scan this QR code and sign up. There are so many different times available, and you'll get compensated $30 for it.